My name is Micheál Healy. Micheál is the Irish name for Michael, and I respond to both. Being an Irish person, I graduated in Cork at the University College Cork in 2009. At the time, University College Cork was one of 2 dental training schools in Ireland. I moved straight to London after that, and I operated in the Kent area in general practice. I did a few courses and continued with education. I carried out my fellowship exams at the Royal College of Surgeons, but after about 7 years in general practice, I decided to do further training. I was interested in prosthodontics. Prosthodontics I felt was an interesting one because I was constantly faced with issues in the clinic. Why is this bridge not fitting? Why is this denture not fitting? And it was the lab element of the training program that interested me the most. After doing some research, I decided that the training program at Guy's Hospital, which is part of King's College London, would be the best program for me. It allowed me to work part-time during the 4 years of training, which is important not only financially, but it allowed me to take what I had learned on the training program and practice it in a clinical setting immediately. After in 2020, I finished the training program in the midst of the pandemic. I achieved my MClin Dent and also passed my membership in prosthodontics with the Royal College of Surgeons in Edinburgh. And I then was registered as a specialist in prosthodontics. From there, I moved back to Ireland to work in a referral clinic where I have been for the last 4 years, before now also working and operating in the UK. The Kingdom Clinic is a referral clinic which is based in Clarney, which is a small town in County Kerry in Ireland. It was set up by a periodontist called Tom Allen, who also is London trained, and he set it up in 2018. In 2020, he advertised for the role of a prosthodontist in the British Dental Journal, and that's how I come across the role there. It's a referral clinic, and Ireland has a very strong referral culture, so it didn't take long for me to build up a list there, where I was carried out pretty much full-time prosthodontic only treatment. I am still, I believe, the only operating prosthodontist in County Kerry. Dr. Tom Allen set up the clinic because he saw a gap in the market because there was no specialist referral clinic in the whole county. Up until that point, patients had to travel quite far distances to cities such as Cork and Dublin to have specialist care. So it feels quite rewarding to be part of a clinic that's bringing specialist care to more rural parts of Ireland. At Alpha House in Birchington, I carry out prosthodontics as a visiting specialist. It is a general practice, but they also have a visiting endodontist and oral surgeon, and I operate there part-time. And I started my role there in January 2024. Composite is a cosmetic filling material, and we live in an age where through social media, patients have a very high expectation and demand when it comes to composite bonding. So the aesthetic challenge that treating cases with composite presents will always be there. Thankfully, there are specific techniques and workflows and courses that can assist practitioners in that regard. With regard to the technical aspect, isolation is also very important when it comes to composite. Very important posteriorly, but also anteriorly to achieve an effective seal. Again, thankfully, rubber dam courses are more abundant than ever before, and thankfully, dentists seem more interested in rubber dam than ever before, which I think is going to really impact in the longevity of our restorations. From a case selection point of view, I think understanding the limitation of composite is important, and understanding the composite that we're using. So composite, for example, is a really good aesthetic restoration, which has high flexure strength, but perhaps not as high as other restorative materials. So understanding the limitations of composite is also a challenge that I think needs to be understood. Rejection moulding is essentially replicating a wax-up intraorally, which has been accepted by a patient. A flowable composite is injected through a clear stent, And modern technology and advances in composite have allowed for this to be possible. Injection molding allows a predictable aesthetic outcome, meaning that we can pretty much guarantee an aesthetic outcome in advance of treatment. This can be trialed during the mock-up appointment, whereby the wax-up is trialed intraorally. The patient can then look, listen, and feel. Look at the cosmetic appearance of the wax-up or the mock-up, listen to any phonetic changes that might occur through the treatment, but also feel the material intraorally. For me, I think this is really important in the consent process, and again, another advantage of the technique. The fact that it's predictable also means that it can be repeated, so the clear stent itself can be kept for a patient, and inevitably over time, if the restoration needs to be repeated or carried out again, it can be carried out to the exact same aesthetic outcome that was decided. Generally, there are cosmetic indications, so it can be used to do composite veneers of teeth for cosmetic reasons. For example, short teeth that are spaced. Even minor orthodontic camouflage can be treated effectively using the injection molding technique. The other kind of big indication for the injection molding technique is tooth wear. So attrition, erosion. We know that kind of moderate or severe tooth wear is usually a combination of erosion and attrition. And I personally find the injection molding technique works especially well in the management of tooth wear. The planning of the case is followed as usual, and I find from my personal experience that the outcome of the material in the 4-year follow-ups that I've done have been very effective, because in tooth wear cases we are adding more material, so we've got the material bulk and thickness, which I think really adds to the strength, but also reduces the incidence of chipping. My favorite material for the injection molding technique is Genial Universal Injectable, which is by GC. Genial Universal Injectable is a flowable composite, which is essentially a nanocomposite. So it uses ultra-fine barium and silica particles, which are densely packed into the resin matrix, which allows for a really high filler percentage to be used. They also use FSC technology, which essentially is pre-silinization of the fillers so that they have more affinity with the resin matrix, which is part of the reason why it has such durable characteristics. The densely packed filler content also is one of the reasons why it has such optimal strength, wear, and aesthetic properties. One of the interesting things that I find about Genial Universal Injectable is the fact that it offers the strength that paste composites also offer, but in a flowable material. Previously, we couldn't really achieve the strength of in our flowable materials. However, with the nanotechnology and the highly packed filler content, we now have a material which is high in strength but also flowable. And GC have also shown me data which shows how Genial Universal Injectable compares very favorably and better against other paste composites. I've been using it since 2021. I have my first experience with Genial Universal Injectable was an online course that I did with GC by Dr. Adrienne Texero, I believe, and that was in 2021. To say it changed the way I work is an understatement. I've been very blessed in my job in Ireland to receive a lot of tooth wear referrals. So it's a practice that I carry out several times a week. And I love discussing the technique with colleagues and friends, as I feel that we all can learn from each other's mistakes. Although it does allow a really high degree of predictability, I think that training in the technique is also important because it is quite simple. However, I think training is key in order to achieve the best outcome. I would say it is an easy technique to pick up, absolutely. The reason why I learned the technique myself was because we live in an age where aesthetic dentistry is everywhere. We're living in an Instagram and TikTok world, and patients are attending our clinics having a very high demand for an aesthetic outcome that's predictable. And I wanted to be able to deliver that outcome predictably on a daily basis for patients. I was a little bit concerned that my freehand skills might not live up to the required standards on a daily basis. So I did the course for that reason. Yes, so I've been running training courses in the technique since 2021, which has been held in Dublin. It's a full hands-on day course. The courses are aimed at both delegates who have never used the technique before, but I also encourage dentists who have used the material to come along too. I bring my experience in using the product and the technique to the course, along with my understanding of tooth wear and treatment planning, which I gained during my prosthodontic training. I really believe in sharing ideas and learning from mistakes. And on the course, I explain my experience, but also all the mistakes that I've learned in the course and all the tips and tricks I've learned by attending 3 other courses myself. I think it's very important to learn the technique effectively, because we all know if we attend a course or if we start using a product without being shown how to use it properly, or perhaps, having poor case selection, that we don't actually use it. So on the course that I run, I really spend a lot of time discussing case selection. And I think starting off on the right case is very important in order to not be put off by the technique. I think it's important to understand and see the technique from start to finish, but also to learn from the experience of somebody else in what to do and what not to do. The alternative tooth technique is whereby 2 models are created. One waxed up with, for example, all 6 teeth waxed up, and a second model where the alternate teeth are waxed up. A clear stent is made on both models. When injecting the alternate teeth, in the first instance, the clear matrix is used on the alternate model, meaning that the teeth which aren't waxed up, the stent seats firmly down on. That means that when I'm injecting the 3 teeth that are indicated in the first go, there'll be less flexure of the stent, meaning that there's less cleanup and a more accurate fit of the stent. Once the first 3 teeth are injected, the second stent, which was fabricated on the wax up of all 6 teeth, is then seated, and the alternate remaining 3 teeth are then injected. With regard to direct composites, I also utilize the layering technique, which is especially important for polychromatic teeth and is required when we're treating teeth which are fractured, but we don't have time to plan the case in advance. I first started using the layering technique during my training at Guy's Hospital, and it was introduced to me by Dr Costas, now of ProstoWorks, but also who was a teacher at Guy's Hospital. So it's quite common that I will use the layering technique, but also more recently, I've used the layering technique in combination with injection molding, so that I'll layer the enamel, the opaque dentine, and the dentine shade, and then the final layer will be injection molded on the buccal aspect. Digital dentistry is definitely my favorite workflow. So that would be the workflow that I carry out the most, both when it comes to planning my composite cases and tooth wear, but also always for my indirect cases. So when it comes to composite bonding or the injection molding technique, I'll carry out a intraoral scan and a digital wax up is carried out. The digital wax up then is sent to me by my technician, and I verify that in advance of the model actually being printed. So that saves an awful lot of time, and also allows me to see any issues with the wax up in advance of it actually being printed. Back in the day, the wax up would be done conventionally and sent to me, and then after a couple of weeks, if there was any issues with the wax up, I would have to send it back. The fact that we can do a digital wax up and that this can be verified before the model is printed is a really important and a key advantage of the digital workflow. With any restoration, aesthetics is always a challenge. Thankfully, we have an array of different types of material to use now indirectly. Lithium disilicate, obviously, but zirconia now is a lot more aesthetic than it used to be. We can use higher translucency zirconias, which can give us really excellent aesthetic outcomes. With regard to retention and resistance form, those principles still apply and are very important for conventional restorations. However, as we move more towards adhesive technology, the use of isolation and effective and high quality use of the rubber dam is very important and always a challenge. Also, another sort of an aspect in relation to indirect restorations is the biological harm of it. So, in the past, we would have prepared every tooth for a crown, and we learned that a proportion of teeth which have been crowned end up having root canal treatment. So using a more minimally invasive approach to treatment with partial coverage restorations to reduce the biological impact on enamel, but also the pulp, is a challenge and important to be aware of. I tend to favor a digital workflow. So in advance of the tooth preparation, I'll take a digital scan of the teeth, and it almost acts like a chairside articulator. It allows me to assess the occlusion chairside in advance of prepping the tooth. Sometimes I'll decide that I want to have a digital wax up and a printed model made so that I can use that for the temporization stage. After prepping the tooth, the digital technology allows me to assess my margins chairside in real time, but also in a cast stone version, which I find really useful. AI also can show us an automated margin. So if there's any doubt for the technician, that this can also be helpful. So the digital workflow for me is really useful, both before preparation, during and after preparation, and also with the wax up and the temporization stage. There's a few standout materials that I use on a daily basis, which are GC products. For regular filling restorations, I will use Genial Paste Composite, posterior for posterior restorations, and the anterior version for the anteriors. I find that this material has excellent handling properties, and also there is a wide variety of shades, which also allows me to carry out a layered approach to treatment. It also polishes very well and has excellent strength and wear characteristics when compared to other products. GSEM by GC is also another product that I use. I find that this gives us some of the adhesive properties of resin cements, but also from a practical point of view, allows for very effective cleanup by tack curing. And I think that this is very important in order to avoid excess cement subgingivally. Another product that I use on a daily basis would be the modeling liquid and the GC brush, which, to be honest, I can't live without. So I've always found the support from GC excellent. Ever since I started using the products back in 2016, there was always regular visits from reps, which it was clear to me that the customer experience was very important for GC. When I became a key opinion leader for the brand in 2021, I received even more support in terms of education and training. For example, GC ran train the trainer events both online and in person, which I was invited to, which was really useful to try out new products such as Genial Accord, which was also, a newer product that I'm using more of. GC are at the forefront too also of modern technology, and I receive regular updates from product management about products that they're trialing even before they're launched, and I find that very useful. In general, I think any conversation about the future of dentistry has to include AI and how AI is incorporated into dentistry already. We're seeing the benefits of AI even with regard to note-taking and patient charting, to diagnostics, to image evaluation, to preparation, through the use of AI in our digital scanners for automated margin detection. So the future of dentistry is really interesting from an AI perspective and how that can be used to improve what we do as operators, but also the patient experience from the very beginning. I'm interested in the development. Personally, I'm interested in tooth wear and the use of the digital scanner to both detect and monitor tooth wear over time. I think that this is really important, as we know that tooth wear can become very severe and pathological. And I think as we maintain our teeth for longer, that the early detection of it is important. With regard to materials themselves, I would say that the development of CAD/CAM posterior restorations, which are adhesive and high strength, is the long and indicated for severe tooth wear in posterior teeth is the key challenge. Perhaps the products are already out there, perhaps the material science is already out there. However, we do need the clinical trials to see that they are effective long term. With regard to lithium disilicate, I think that we're in a strange place. We're kind of in the middle with it. Originally, lithium disilicate anteriorly was the go-to for optimal aesthetics. However, now with more translucent zirconias, I personally am finding that we're achieving excellent aesthetics anteriorly. And for anterior full coverage restorations, which have favorable retentive properties, I'm going for zirconium more than lithium disilicate. Posteriorly, lithium disilicate is a really good material because of the adhesive properties of it. Okay, we can bond zirconia now. However, for me, predictability of the bond in zirconia is not as strong as it is for lithium disilicate. So for posterior restorations, we can do lithium disilicate or Emax onlays. However, lithium disilicate is not indicated in patients who are bruxists. And we know that a huge percentage and an increasing percentage of our patient base are bruxists. However, the question needs to be asked also, is it not indicated, or have we just not completed the clinical trials to tell if it is? Partial covered restorations are going to be cemented with resin cements. We know from lab studies that cementation with resin cement increases the flexural strength of that material significantly. So perhaps bonded lithium disilicate restoration posteriorly could be indicated in more severe tooth wear cases. I think future research in this area will really answer a lot of questions, but I'm also interested to see what other products and what other materials can be offered. So we know that the adult population are retaining their teeth longer than ever before, which is one thing. So obviously we're going to see a pathological level of tooth wear over time. We also know that tooth wear is not age-related. A 2013 pan-European study showed that 29% of 18 to 35-year-olds had moderate signs of tooth wear. So we're seeing tooth wear both in younger patients, but also in older patients that is moderate and severe regardless of age. So we need to think about a minimally invasive approach to the management of tooth wear, and actually the European consensus statement in the management of tooth wear states that a minimally invasive and adhesive approach to treatment should always be used as the first port of call. With that in mind, there is a good argument to be used for composite in the management of tooth wear, both anteriorly and potentially posteriorly. As I said previously, I think, like longer term clinical trials will give us more long-term data on the effectiveness long-term of composite posteriorly. We know anteriorly that composite does well, at least in the medium term. So it'll be interesting to see the outcome of future trials.